Sick and incurable, or a model of perfect health. Britain's NHS, the National Health Service, costs almost $150 billion a year. Who's going to tell the patient it's run out of time? This is Roundtable with me, David Foster. There are those who argue that with the NHS still sometimes being called the best in the world, it is time to reassess what Britain offers those who need treatment, either occasionally or much of the time. What was once innovative is now creaking with age. There are fitter, leaner and cheaper models out there. In the UK, maybe it's time to think again.
It's seen as one of the foundations of modern British society. Established after the Second World War and based on the ideal that good healthcare should be available to all, regardless of wealth. Britain's National Health Service is experiencing increased demand from a population that is both growing and ageing, and funding that's not increasing enough to cope. NHS services have been under intense pressure. Patients left in corridors, delayed operations, staff shortages, and in some cases, deaths that could have been avoided. There are many that feel that the system is at breaking point, and if a solution isn't found soon, it could have a direct impact on people's lives.
A patient of mine who was an elderly lady who had a fall and developed severe abdominal pain, and she went to our local A&E department and had some tests done but wasn't properly assessed for several hours, and it turned out she had perforated her abdomen, and in the end she died from peritonitis, which was completely avoidable.
There's a shortage of doctors and nurses, and at the end of last year, thousands of patients had their operations cancelled, forcing the Health Secretary to apologise to the British public.
I want to apologise for the fact that we have had, regrettably, to postpone a number of operations. We're trying to do it differently this year. Last year we cancelled a lot of operations at the very last minute, so people got a call the day before to say their operation wasn't going ahead. That is obviously very undesirable, so we want to do it in a much more planned way.
Up to 100,000 patients this winter have had to wait in an ambulance for at least 30 minutes because of overcrowding in accident and emergency departments. For 70 years, the NHS has received an average of 4% increase in its budget each year. But after government austerity policies, it's now 1.2%. And it's claimed that by 2022, the shortfall could be as much as $27 million.
My last trainee decided they don't want to practice medicine anymore. Morale is that low. We know that doctors within 2 years of qualifying in the NHS are leaving the NHS. Either they're going abroad or they're giving up medicine altogether.
A health model held in high esteem, it is free and open for all UK residents. But can the NHS survive through austerity and all the other pressures it faces, while remaining free, accessible and maintaining its global reputation?
Very pleased to say that joining me at the round table we have Bob Gill, family doctor and NHS campaigner, making a documentary about it at the moment. We have Christian Niemitz, Head of Health and Welfare at the Institute of Economic Affairs, written some fairly thought-provoking articles. Heather Henry's here too, chair of what's called the New NHS Alliance, and we welcome back Sanjeev Krishna, Professor of Molecular Parasitology and Medicine at St George's University of London. And all of you, thank you for coming in, have given some time well before this programme in thinking about how we can cure the ills of the National Health Service. So let me ask you first of all, Christian, there's an article that says the NHS is not worth defending. Well, we all love the NHS in one way or another. I think as Britons we're pretty proud of it. So why is it not worth defending?
Well, I would ask the reverse question. What has the NHS achieved that virtually every other healthcare system in the developed world hasn't also achieved? What people normally say is it covers everybody, irrespective of ability to pay. And that's true, but that's true virtually everywhere in the developed world. That's true of virtually every single healthcare system in the rich world. The US is the only outlier here.
But it's not worth throwing it out. It is still worth defending, even if there are other good ones out there, isn't it?
Well, not if the other ones and some of the alternatives have much better outcomes, which they have across the board. If you look at international comparisons of healthcare outcomes, you will...
Which is whether you get better or not.
Yeah, so survival rates for cancer, for strokes, measures of avoidable deaths. You will always find the NHS somewhere in the bottom third, normally in the vicinity of Slovenia and the Czech Republic. And you will normally find the social health insurance systems of the type that they have in Switzerland, in the Netherlands, somewhere pretty close to the top. So if those systems are doing better, why not copy a system?
Who represents the defence of the NHS here? I know you all think there should be changes, but perhaps it is time to think again.
Well, this is a spurious argument we're hearing. We hear about outcomes, but you're not comparing like with like. For example, the outcomes on the population are dependent on many factors. The economics, the lifestyle of the population. It's not purely a product of the health system. And what we're also hearing is nudging towards an insurance-based system. Well, the NHS has prevented the siphoning off of money by insurance companies for 70 years. But what the IEA want to promote is the conversion of our system to an private insurance-dominated system. And this is the rhetoric we're getting. So we're getting the NHS...
But when you say health outcomes are affected by a variety of different things, well, that's clear. It depends where you live, it depends what your lifestyle is. But the fact is, we do come way down, even in the most favourable surveys of health systems, we come way down in this health outcome things, which is whether you get better or not, and that's the raison d'etre of the health service, isn't it?
Sure, but if you look at people's lifestyles, if you look at their economic circumstances, if you look at smoking levels, alcohol levels, obesity levels, those are outside of the gift of doctors and nurses working in the NHS. They are more to do with public policy, they're more to do with advertising on television. Other countries in Europe, certainly Southern Europe, have far more healthier lifestyles, far less levels of obesity. Another thing about the NHS is we're very good at collecting data. So our data set is comprehensive because we have a universal, comprehensive health system, whereas other data sets which we might be comparing to here aren't as complete and thorough. So, for example, in Germany, they might not be collecting all the data, which might reflect badly on their health system.
And this is one of the things, I think, Heather, that you want to change, with your nursing community work that you're doing, is the way people perhaps get ill.
Yeah, well, the Alliance is now focusing on health inequality and innovation to tackle health inequality.
What does that mean?
And, well, in terms of what people have said so far, what Christian mentioned in terms of healthcare outcomes, what we have to realise is that actually health isn't healthcare. And what Bob mentioned was we have to take into account the social elements of what we're talking about. And if we look at work that's been done, particularly by people like Richard Wilkinson, who is an epidemiologist, we can see that a lot of healthcare outcomes are connected to health inequality. And we know from recent reports that health inequalities are widening in this country. And what's tending to happen is that because people are getting older, people are having long-term conditions, that a lot of the focus is on those things and people who are actually sick. And at the Alliance, we want to think about, well, what are the causes of wellness? And how do we tackle the social injustice of health inequality?
So why is it that when we look at the amount of money that's spent on the National Health Service compared to 1948, which was when it started, is in real terms 12 to 15 times as much now as it was then? And it sort of worked in 1948, perhaps because people were very grateful for it and we were coming out of a major international war, but 12 to 15 times as much now, and it isn't working. Is it? Why not?
I think, well, it's great to be back, David. I mean, in fact, the three views that we've heard illustrate, I think, one of the most deep-seated problems at the moment that the NHS is facing, and that is the lack of a consensus, the lack of the people who are benefiting from the NHS and people who are delivering care within the NHS and the wider healthcare system coming together under a new rubric, because I think it needs a new vision. 1948, the NHS was born, as you've already mentioned, out of a post-war consensus. Politics was put aside, thinking came together, the needs came together as to what society wanted, and eventually the system delivered. Now, I think Christian's wrong that, you know, we don't need the NHS. I just think that's wrong.
I think what he's saying is we don't need the NHS in its current form.
Right, but the people's anxiety, if you ask people out there what their biggest anxiety is you know, their health and the NHS not being around to support their healthcare. That's one of the biggest problems that people have.
But I suppose the point I'm trying to get at, Sanjeev, and anybody else can chime in on this one, is why? Is the money being spent badly when we're spending perhaps 12 to 15 times as much now in real terms as we were when it all started? Is the money being spent badly?
Well, what we have to realise is we need to step back a little bit. How did we get to this current predicament? Up until 2010, public surveys and trust and satisfaction in the NHS were at an all-time high. We've had the financial crash, we've had austerity, and since 2010 there's been a relative reduction in the funding of the NHS. So the NHS has been defunded. Average funding around 4% historical rate of rise. Since 2010, 1%. So
and I think it's about 8% of GDP, isn't it, that we spend on?
Yes, yeah. So that is the figure to look at. How do we compare with GDP spend to other equivalent economies? And we're down the bottom of the league. So we spend less than everybody else. In the last 30 years, we've had the setting up of an internal market, very costly bureaucracy, which is siphoning away about 10% of the NHS
Christian
budget.
was shaking his head at that point.
Well,
I'm going to let you finish in a second,
please,
but I want to know what you think to the first point, which is that we're not spending enough.
We're not in the bottom of the league. We're spending about 8% of GDP on the NHS, about 10% of GDP on healthcare overall. That is pretty much, that's a completely normal figure by developed world standards. That's pretty much in line with the European average and the OECD average. Of course, some neighbor countries spend more, and you can make a case for spending more, but it's not in any way exceptional, the level of spending that we have.
But then Bob was saying about bureaucracy. We have thinned it down a little bit.
Well, the point I'm making, the NHS, if you imagine it's like a bucket, it has two major holes in this bucket. One is the cost of private finance initiative debts and servicing those loans, and the other is the cost of the bureaucracy.
This is where private companies have come in. The NHS Trust lease back a particular building, but they have to pay interest or rent for doing so.
Well, they pay. So we've borrowed borrowed about 11 billion to build NHS hospitals, and we're going to pay back in excess of 80 billion. Now, does that represent a good deal to you? And at the end of the period of the debt, we don't own the hospital.
Was this short-termism that somebody thought it's a political expedient to actually sort of say we're actually sort of getting better hospitals, but the long term is that you're going to end up paying for it?
Personally, I think that we are seeing the effects of politics coming in, whether it's on the left or on the right. And the NHS is too important to be a political football, in my view. Of course, politics comes in everywhere.
Is that new?
Well, it's become used much more as a political football in this country than perhaps in some European countries. So, for example, in Germany, while Angela Merkel is having some discussions with her coalition partners or potential coalition partners about health costs and so on, in this country, there has become a polarization of views. And my feeling is we really need a very high-level look at the overall playing field. And that means, you know, all the components that are contributing to healthcare, including the social side of things, which is not yet properly integrated. We need to see where best practices are working in the NHS, because there are some great examples of real delivery of success and efficiency.
Let's ask Heather, you know, in terms of success stories, because we mustn't malign something that keeps so many people alive. And, you know, I'd be happy to use tonight if something unfortunately went wrong with me. Where do you think it is sans pareil, you know, it beats all the others? Any examples?
Well, I would obviously point to nursing, being a frontline nurse. I think some of the early pioneers of this were the previous chief nursing officer, who identified what it is that's actually costing in nursing terms. And since then we've had really successful campaigns like hand washing, for example, and the management of pressure sores. And I think we've had great strides in terms of efficiencies.
Do we lead the world in this sort of thing?
I think we're getting down to nil in terms of some of the infection risks now in terms of hand washing. I wouldn't know the global comparisons, but I would think at nil.
Something to be proud of.
In many of the hospitals. And all the professions, of course, were involved. But, you know, I think that that's a major achievement. But if you'll forgive me, I think some of this argument needs to be widened. And I think the NHS is predicated on the idea of doctors, drugs and kit. And it's done very well for the last 70 years. You know, I come from Trafford. the home of the NHS, where Nye Bevan announced the NHS. And we've done a really excellent job in terms of assessing needs and delivering services to people. But actually, New NHS Alliance is saying, isn't there something more than that? With that 70% of health outcomes to do with social factors. I get really, this is a very important debate around the NHS. We need to widen it and stop talking about the NHS in a silo. And we've been really good over the last couple of years in terms of talking about health and social care. But actually, the thing that's costing the system money are things like homelessness, substance misuse, and people who have broken the law and how they're treated within the system, not just the NHS. £58 billion is the amount that costs the system.
So you're saying if the approach could be changed, some of, if not all of that money could be saved. Let me ask you, Christian, you pointed at other countries, particularly the way they finance it rather than the way perhaps that they treat people. What best practices do you think they have that could perhaps be adopted in the UK or should be adopted in the UK? And then chip in as he's speaking.
Well, I'm not a clinician. I can't talk about clinical practice. I'm an economist, and I'll stick to that. But what I would say is it's not just a difference in funding. There are implications of that. If you have an insurance-based systems, it means you have independent competing providers, and they are essentially forced to constantly learn from each other, because good ones can expand and bad ones can lose market shares or even go bankrupt. So there's learning from
profit.
Some of them, that depends on what exact system we're looking at. But yeah, some of them can be on a for-profit basis. And I don't have a problem with that. What's wrong with that, as long as the outcomes are fine?
So the central argument against this private insurance model is the cost of the bureaucracy. So the NHS has been deformed over the last 30 years, but before Thatcher's reform started coming in, the cost of bureaucracy was less than 5%. Now we're hovering close to 20%. With the changes that have been happening behind the scenes. America's cost of administration is 30%. The model that Christian's talking about is somewhere in between. So we are being argued by the IEA that it's better to spend more money on a bureaucracy. Christian's Institute. Yeah. Let's spend more money on a bureaucracy, let's spend more money on directors, and let's spend more money diverting to shareholders.
Surely if your raison d'etre is to make a profit, then you are going to be less bureaucratic because you'll be employing fewer people, and therefore you might be more efficient.
So bureaucracy is inherent in the system. That a tax-funded system, you do not need a parallel bureaucracy. Insurance requires to collect the fees, pay the bills, make sure people are eligible, send them out charges for out-of-pocket expenses, hugely bureaucratic. Yep. And the number one goal, particularly in the US, is to make sure you spend the least possible on patient care, and fraud is endemic in that system. So the less you spend, if you can exclude the sick and the expensive, the better your share price. That's how the system works.
Let me ask Bob a question. As a GP, a family doctor I described at the beginning, when people come to see you, and you've been obviously doing it for a number of years, do you find that they are more or less satisfied with the service they're getting these days?
They are less satisfied.
Why?
They're having to wait longer. If they're very ill and they go to A&E, the A&Es are overstretched and overrun. They're not being assessed properly. I've seen patients of mine suffer harm as a result. This is why I'm on your program, because I know where this is going. The Institute of Economic Affairs and other right-wing think tanks are fundamentally, they want to privatize as much as possible, they want to deregulate as much as possible, and they want to get rid of protections for the public.
But if what we have at the moment isn't working,
well,
why not look at another model?
Who says it isn't working? What I've described to you earlier is deliberate defunding. Now, for a government...
You said people aren't happy, they have to wait longer. They lie on hospital trolleys in A&E.
Because it's being defunded and money is being diverted away from patient care. That's not a reason to abandon the system. What I'm trying to do is to tell you the system has been sabotaged for this end. As we had with British Rail, you underfund it for years, you make it a laughing stock, then you hand it over to private capital. That's what happened. That's the same process that's happening in the NHS. how could our government persuade us for top-up charges if it was running smoothly?
Okay, but the problem is we don't have a great deal of money to go around, and if Bob is suggesting we put more money into it, where does it come from, et cetera, et cetera?
So we need to think at a higher level now, because we've got a very complex system. It's a huge employer, 5th largest in the world, probably, after the American Army and one or two other private enterprises. And to manage it is not easy day to day. But I think we're at a time where, because healthcare costs are going up, as you've described, much more than we can afford, we need a very high-level look at the leadership and how that can influence good practice within the system. We need to think about the whole system in the room while we're fixing bits of it. So we need to think globally while we're acting locally in different areas.
And Heather, I mean, you're looking at a holistic approach.
Yeah.
But on a personal level, how frustrating do you find it working within the NHS?
Well, I don't work in the NHS. I was made redundant 7 years ago.
Well, forgive me for not thinking that as your work was part of the NHS. Okay.
And this leads to a very moot point. What about the contribution of the voluntary and community sector? What about the contribution of social enterprise? And crucially, what about the contribution of informal carers? We don't talk about that. We don't talk about the army of carers and how much they save the NHS. This is a silo conversation. And something else is around...
By which you mean we're sort of stuck in one place and
we talk about the NHS in isolation. If we're lucky, we talk about health and social care. But if you'll forgive me, the NHS is going to turn 70 this summer. And we set it up as an institution really in terms of the identification and management of sickness. But what about wellness? The public health budgets in this country have been cut almost to the bone. And so we have to think about how far have we got with looking at population health? Because we don't talk about population health. We talk about mostly what we've been talking about here today. So we managed to get good sanitation. We've managed to control most infections. We've got a good welfare state. And we're going on and on about lifestyle. The people I work with, the people on the streets of Greater Manchester, they know what to do in terms of making themselves healthy. But we've got to think about the circumstances of their lives.
You know, the thing is, we talk about it, or everybody seems to assume it's free. It's not free. We pay in this country something called national insurance, which is effectively a tax. Wouldn't the simplest thing to do, to be honest with the public and say, look, we haven't got enough money. We're working on trying to make this better, but your national insurance is going to have to go up. That way we will have that extra 350 million a week that the Brexit people boasted about. We would have that, and we could fix it that way.
Well, can I...
Be honest with the public.
Can I argue again? I agree we need to be honest. We've had a covert destabilisation for the last 30 years. You know, the Institute of Economic Affairs, one of the editorial directors, Arthur Selden, produced a pamphlet in 1968 after the NHS. Then we had Oliver Letwin and John Redwood, who devised a program to covertly get us from a publicly funded system to an insurance-based system. We're far down.
Let me ask you then, do you think that will happen?
Well, we're set up for it. So we've got an infrastructure for charging being introduced across the NHS on the back of charging immigrants. But they're not investing just to charge immigrants, it's to charge everybody. Oliver Letwin's own paper talked about charges to the point of universality, a document he produced in 1988 called Britain's Biggest Enterprise. So all the levers behind the scenes are set up.
No, we've got about a minute and a half left, so I'm going to ask Christian, because since you were the attack dog against the Institute for Economic Affairs, just to come back quickly and say, do you think an insurance-based system in this country is inevitable? In other words, is the NHS as it stands at the moment doomed?
No. It would require a major shift in public opinion, and I don't see that happening yet. But to address this point that there is some secret plan to replace the NHS with an insurance system, and this is a conspiracy theory which has been around for over 40 years. I wrote a book about the NHS. I've looked a bit at the history of this claim. I found articles going back to the early 80s, the late 70s, saying exactly the same thing.
Quickly, if you don't mind.
Sorry?
Quickly, if you don't mind. We've got 1 minute left.
Yes, this idea has always been around, that there's some secret plot to privatize the NHS, but somehow after 5 years later, it is always there. So no, it's not happening.
I think we should ask the public, we should involve the public, who are the main users, of course, because if I'm sick and I go to see a doctor or a healthcare professional and ask their advice, I want to be just happy that the decisions they're making are not related to what they can afford, but that they're looking after my best
Final
interests.
quick word. Let me ask you, Heather, as we come to the end, a yes or a no answer to this, please. If you, unfortunately, were to fall ill later today, would you be happy to go and be treated at the hands of the National Health Service?
Absolutely.
There you go. Couldn't be more clear. Thank you very much indeed. And Bob, I'm terribly sorry we didn't get to talk about your documentary. Perhaps you'll come back on another occasion and tell us what you've discovered about people's opinions of the National Health Service. Thank you all very much indeed for coming on this edition of Roundtable. We've been talking about the National Health Service in the UK. It's been around for almost 70 years, so it's officially an old person or an old institution. It's still on its hind legs and it's still trundling along, although I think, as we've discovered this afternoon, it could be feeling a bit better. From me, David Foster, thank you very much for watching. From the entire Roundtable team, we hope to have your company next time. Bye-bye for now.